Thank you all for attending today's webinar on optimizing daily mouth care for residents in long-term care, which is presented by members of the BC Dental Association. I'm sure everyone has the routine down by now, but just to a reminder that you're all automatically on mute with your videos turned off, and you'll only be able to see the slide deck and the video of those that are speaking. If you have any questions during the session, we ask that you please use the Q&A function, not the chat. That way we can moderate them throughout the session and potentially answer some of the questions throughout the session. I'll now turn it over to Carrie Chan, Manager of Corporate Communications and Public Affairs with the BC Dental Association, to introduce himself and the rest of the team that I'll be presenting today.
Thanks, Melissa. Thanks again. My name is Carrie Chan, as she mentioned, and I'm the Manager of Corporate Communications and Public Affairs for the BCDA. On behalf of the BCDA and its more than 4,000 members, we'd like to thank everyone attending today's webinar and also thank the BC Care providers for hosting today's session. With that, I'm going to introduce our panel of speakers today. Leading the discussion is Dr. Salima Dadani. She's the director of BCDA's member support team, who also owns a mobile dental practice that specializes in comprehensive on-site oral health services for those who find it difficult to visit a traditional dental office. Dr. Dadani is passionate about geriatric dentistry and is an advocate for quality oral health care for seniors. Joining her is Dr. Nicholas Tong, a practicing dentist in Vancouver, as well as assistant professor with UBC's Faculty of Dentistry in the Division of Prosthodontics and Dental Geriatrics, and is also the program director of the General Practice Residency Program there. Dr. Tong is also the chair of BCDA's Geriatric Dentistry Committee. We'll have Dr. William Van Sickle, who is a general practitioner who is based in Prince George and has been practicing dentistry for over 40 years. Dr. Van Sickle is very interested in oral health for seniors and is an active member of BCDA's Geriatric Dentistry Committee. Finally, Dr. Richard Wilczek, who also practices in Prince George, is one of the founders of the Dental Studies program at the College of New Caledonia in Prince George. Dr. Wilczek provides emergency or residential dental care to seniors and also co-founded Prince George's Emergency Dental Outreach Clinic, who provides dental care to socioeconomically challenged folks as well as seniors. With that, I'm pleased to pass it over to Dr. Dadani, Dr. Tong, Dr. Van Sickle, and Dr. Wilczek.
Thanks so much, Carrie, and welcome to everyone on this webinar. Really glad you could join. I'll ask my co-panelists to please turn on your cameras, and this conversation is going to be conversational, even though we do have a slide deck. Each of the panelists practices in a slightly different environment, and therefore having all of their perspectives will make for a much richer conversation. So I invite each of them to add any perspectives that they wish as we go through the slide deck. And as Melissa mentioned, if you have any questions, we'd love to entertain them either during the presentation or at the end. And so with that, we'll start with the first, we'll start right away. So the outcomes that we anticipate and we hope that you come away with is to learn to understand the challenges to mouth care, especially during the COVID-19 pandemic, to understand the health implications with compromised oral health, to discuss the role of the care aide, the nurse, family member, and dental professional, and finally, to be aware of the resources that are available to you in this area. So first, really speaking about the challenges to mouth care for residents in long-term care, and there's many challenges. The first is this idea that the resident is too old or too sick or too frail for dental care. Having good oral health is important for everyone, no matter how old they are. So the comment that my mom is 95, why does she need her teeth cleaned? That doesn't ring true. It's important for everyone, and we'll discuss why in a few minutes. Sometimes there's difficulty in accessing professional dental care for elders, especially in long-term care, due to mobility issues and financial concerns. The second piece is around not having enough time, and this is for the care aides and the staff, or not enough training. I've done a few in-services where I've had care aides relate to me that the training they had in school was minimal when it came to mouth care, and that many of them would rather do other tasks than try to help an elder with their mouth care. It's not that they don't feel it's important, it's just that they feel intimidated by it. An article from 2020 in the Journal of Clinical Nursing talked about how the average time spent brushing teeth was only 60 seconds. And, for any of you who have children and go to the dentist, we are always talking about that you have to sing the happy birthday song twice in order to have good brushing time. Well, I'm telling you, nobody can sing the happy birthday song twice in 60 seconds. And that's really because of the complications, the challenges that are there for these elders. And finally, it's this idea of waiting until there's a problem. Many elders, and this was in the BCDA report on seniors' health, November 2008, talked about waiting until there was actually a problem, not being proactive with their dental care. And oftentimes when they wait till there is pain, sometimes the issue is really great. Sometimes the cost is much higher, and the impact, the medical impact, the other impacts on the senior are also much greater, especially if emergency treatment is required. I know that Dr. Wilczek, Dr. Tong might have more to add, so I'll ask them to just go ahead.
This is Dr. Wilczek. You're right, Dr. Dadani. Seniors rarely complain of problems. They're the least complaining part of society, and to wait for them to complain is really the wrong time. They really have to be assessed, because the treatment we deliver is not overly complex. Just the patient is extremely fragile, but that is not a complaining population. That's been my experience.
Yeah. Hi, Salima. Hi, Dr. Wilczek. Hi, everybody. This is Dr. Tong coming. I'm actually in long-term care today at our long-term care clinic. I'll give you guys a little view of what our clinic looks like down in Chinatown in Vancouver. And that's with the BCDA Geriatric Dentistry Program. But I totally agree with what Dr. Wilczek said. Seniors are not a complaining population, and it's really important that, both nursing staff, care aides, and dentists are looking in their mouth and, helping to identify issues that might arise. And I think all the things that Salima has listed here on this slide are totally right. Thanks, Salima.
Great. So we know as elders age, as all of us age, there's increased risk to our oral health. This is a bit of a crowded slide, but if you just bear with me, the first thing is decreased cognitive ability. So the elder might be forgetful about remembering to brush, even though they may be able to brush, they may be forgetful. And it may be the role of the staff to just remind them, Mrs. Smith, it's time to brush your teeth. Here's your toothbrush with toothpaste. Sometimes for elders, there's confusion around brushing their teeth. They don't remember brushing their teeth, or they don't remember how to brush their teeth. Sometimes it goes so far as not being cooperative, and that's when it becomes very challenging for care staff. The second piece is, as we get older, it's harder for us in terms of motor function. We may not be as good with our hands that we used to be. We may have arthritis, and so it may be harder to hold the toothbrush handle, and definitely it may be harder to manipulate floss. I think flossing is difficult for most people, and so as we get older, it becomes a little bit harder. But there are things that can be done, and we'll talk about that as well. As we get older, we may have increased medications, and some of these medications may cause us to have a dry mouth. Some of these medications may be delivered in a sugar-based suspension, both very negative for oral health and the state in the mouth. The next piece is decreased appetite. As we get older, because of our teeth, perhaps not because of our teeth, we may have a decreased appetite, and we may depend more on high sugar-based snacks and drinks. We might also have mouth issues, which make it harder to eat certain kinds of foods, which are actually healthier, like crunchy vegetables, sometimes meat that is more difficult to chew. As we get older, we may have some diseases that are very much tied to the health in our mouth. If we have more bacteria in our mouth, it can lead to respiratory infections. Uncontrolled periodontal disease, or uncontrolled issues with the bone around our teeth, with the gums around our teeth, have been tied with cardiovascular disease, as well as the ability to control our sugar levels and diabetes. And as we age, of course, there's an increased risk with cancer, all cancers, including cancer of the mouth. There is initial research right now into the link between uncontrolled periodontal disease and the progression of dementia as well. Dr. Wilczek, Dr. Tong?
One of the other issues that I also see is a lot of times the care aides, the patients refuse very slightly, or they're told because they're just slightly confused. It feels like they don't give consent. And it almost gives an excuse for the care aides not to want to help them with the care. And that is a tough one, because a lot of them, they just will not, it looks like they're not giving consent, or the question is asked improperly. It's a problem.
Yeah, thanks, Dr. Dadani. Yeah, I'm sorry, I'm just going to keep my video off just because I think my internet connection is a bit unstable. Sorry, guys. But yeah, just one comment about, the relationship between oral health and the progression of dementia, because I think that's one that's, really fascinating for us as dentists, and for our geriatric medicine colleagues and our nursing colleagues in long-term care. There is some emerging evidence, and there is a bunch of biological models that have been suggested to explain that relationship. Certainly, one of the phenomena that we do see is persons living with dementia are certainly at high risk of tooth loss, and that's certainly well documented. And I think there's a lot that can be done both at the home hygiene side, done by care aides and family members and caregivers, as well as on the dental side, stuff that dentists can do to help prevent tooth loss in patients. So hopefully they can maintain their teeth, throughout their life, which is what we as dentists want. Yeah, thanks, Salima.
Thanks, Nicholas. So now, with compromised oral health, what are the health issues for our elders? So the first thing is that frail elders today have more teeth than they've ever had. So dentistry is getting better and better at preserving teeth. And therefore, as we get older, we're able to keep more of our teeth. But keeping more of our teeth means that we have more teeth potentially that could be impacted by all of the things that we just talked about. We often see in frail elders this idea of root caries and rampant decay. That's a photo from one of my colleagues showing the extent of the decay that we see in elders, as well as root caries, which is decay along the gum line. How do we prevent this? So the first is having ongoing oral hygiene, the cleaning of the teeth daily and professionally. Daily by either the resident themselves, or with help from the care aide, or completely by the care aide, and professionally by the dental professional. Making sure that they have the appropriate diet, and that means trying to limit the amount of sugar and carbohydrates, especially in between meals. And so oftentimes, and I'm sure Dr. Wilczek, Dr. Tong will share their own experiences, but often seeing elders with a lot of food stuck around their teeth, in between their teeth, especially on the gum line. And this we can see is carbohydrates that they're eating, the cookies, the breads, as well as the sugary kind of drinks, the juices that they may be having. There are some things that can be done. The best is, of course, the daily oral hygiene and the professional dental exam, dental cleaning. But as well, there's other things that also can be included, including fluoride varnish, which is a high dose of fluoride, which is painted onto the areas of the teeth that are susceptible to decay along the gum line. And it's sticky and it lasts a long time on the teeth, really trying to bring the fluoride to harden the tooth surface to prevent it from being susceptible to decay. A fluoride rinse for those who are able to swish and spit. And using an increased fluoride containing toothpaste, such as Prevident 5000, and also the chlorhexidine rinse, which is prescribed by the dentist. All of there are a lot of documents. They're listed on the slide deck. So if you do want references for later, please do visit the recording and you'll see the different references, including this one, which is by the Canadian Dental Association. Dr. Wilczek?
Thank you, Dr. Dadani. You're right. Caries is a big problem. I always see food in between their teeth, primarily oatmeal, because I usually see them in the morning. I'm a big fan of chlorhexidine. I prescribe that to anybody that has had extensive dental treatment, like with crowns or bridges, and I want to preserve them. I try to keep them on a chlorhexidine rinse. I don't use fluoride rinse as much, and because I think the chlorhexidine, it seems to work. The other thing that we're experimenting with is a silver diamine fluoride. We're putting that on all the caries or all the areas because aesthetics are not, I don't feel that's a high priority for the seniors. How effective that will be, I'll tell you in a few years. But we're using that a fair bit in Prince George, or I'm using that in Prince George in my practice.
Thank you. Dr. Tom?
Yeah, thanks, Dr. Dadani. Yeah, no, I think your slide is very accurate. And I'll make two comments. One is with regards to diet. So certainly in long-term care, as I'm sure all the folks on this call are very aware of, the diet textures that are prevalent in long-term care are typically softer. And a lot of my patients in long-term care are on either a minced diet, a cut-up diet, or a pureed diet. So those that have some level of dysphagia, issues with swallowing that can be related to cognitive decline or related to other neurocognitive disorders, are often sort of, they do this transition into that very soft diet. Well, those soft diets are extremely cariogenic in the sense that they're very cavity promoting. So, when soft foods are stuck around all the teeth, around all the fancy crown and bridge work that's been done, around all the fillings that have been provided for the patient throughout their lifetime, that certainly increases the risk of them developing cavities when they're in long-term care, that soft diet. The other comment that Dr. Wilczek made with regards to silver diamine fluoride, that's a product that we are also using really well here in Vancouver, and we've had really good success with it so far in our long-term care population. It is an area of continuing research in the dental literature to look at the efficacy of it in long-term care patients, but our anecdotal experience with it here in Vancouver in long-term care patients is that it is quite effective so far. So, but I'm with Dr. Wilczek in saying that, I am curious in a few years to see what the true effect of it is. And I will also be keeping an eye on my patients for over time to see what the true effect of it is. But it is a new product that was only approved by our government agency several years ago, within the last 10 years, and we're starting to use it more and more now for certain cases for long-term care patients. Thanks.
Perfect. So the next issue we're going to talk about is a dry mouth xerostomia. And this is a huge contributor to an increase in cavities. We know that we need saliva in our mouths, but we may not know that we need it for buffering. And what that means is that it prevents our mouth from becoming too acidic. The saliva also cleans our mouth in the sense that it removes some of the debris from our teeth. The key is when a person has a dry mouth, and again, the dry mouth can be caused by age, but it also significantly can be caused by some medications, that they should be avoiding alcohol-based mouth rinses. So to make sure that if they are using a mouth rinse, that it does say alcohol-free, and there are some products on the market today, mouthwashes that are alcohol-free, and this is really important. Also to avoid are toothpaste containing SLS, sodium lauryl sulfate. That's what causes the toothpaste to foam up. To avoid candies and mints. Oftentimes you may go into an elder's room and there's a big bowl of, Werther's toffees or something like that. That's a big no-no. Now you're introducing a sugary item into an environment that's ripe for decay, causing bacteria. Totally understand that they want those candies and mints because they have a dry mouth. So what are the alternatives that there are? And we'll talk about that. Also to avoid sweet, spicy foods, caffeine, and tobacco. What they should be using are dry mouth products, and there's excellent ones on the market today. To sip water regularly, suck on ice chips, make sure their lips are lubricated, because again, with saliva, we lick our lips and keep our lips lubricated. We want to use sugar-free candies and gum, and that's mainly with the sweetener or the artificial sweetener xylitol. We do know that does not promote tooth decay. And so we want to make sure that we're giving our elders the opportunity to moisten their mouth with a candy, but that it's sugar-free. Again, we talked about dry mouth products, which include artificial saliva substitutes, and to work with the medical doctor to see the medications and see if there's any opportunities to change things up in order to prevent a dry mouth. And of course, most importantly, working collaboratively with the dentist to make sure that they're aware and that they're also on it. Dr. Wilczek, I know, is ready to add, so I'll pass it over to him.
Thank you. One of the things I learned, had this revelation, is that one side effect of xerostomia is that food really sticks to your teeth. So it makes the accumulation of food around the teeth greater. And it just compounds the problem. This is a problem that I have had no great solutions for. It's just something we have to live with. I'm sorry. That's my view.
Yeah. And having a dry mouth often makes it harder to eat and swallow, because if you imagine, you need saliva to create that bolus of food in order to swallow it. So when you have a dry mouth, it's harder to swallow. It's harder to speak. I'm sure today we're feeling that as we do this presentation, that it's harder to speak as we get nervous and our mouth gets dry. You get bad breath, a change in the taste of the food. Your tongue, if it's really severe, your tongue can get swollen and red. You can have painful bleeding gums, burning, and the poor retention of dentures. So it's not a good situation. Dr. Tong?
Nope, I think you covered it all. Thanks, Salima. We can move on.
Perfect. So the next piece is around gingivitis and periodontitis. And so the picture there, it's a little distorted, but it gives you the idea of the accumulation of plaque and calculus on the lower teeth there. And, food debris and plaque seem to cause less distress to frail elders than other age groups. So they may be more okay with it being there than others, but it's not okay to have it there. And although they may not complain, they really need that ability to mechanically debride or move the plaque and the plaque away through toothbrushing. It's important to disrupt the biofilm or the component that where the bacteria are around the tooth. And then, of course, that kind of plaque causes bad breath, and that can inadvertently disturb social relationships, less, wanting of perhaps, family members, grandchildren to be too close because of the bad breath. And of course, really huge is aspiration pneumonia, where some of those bacteria that are in the plaque, in the biofilm, become aspirated or breathed in as, micro little bits of them breathed in and then into the lungs, where then they can cause aspiration pneumonia. Dr. Wilczek, Dr. Tong, anything to add?
I agree, because the dental hygienists we have a dental hygienist that works in all the homes with us. They're a key resource and support for the patients to make sure the hard deposits are clean and just to reinforce the oral hygiene. And actually, the more times we have dental personnel in contact with the seniors, we try to improve that level of care they're getting. And I think that's important for the care aides, that shows that that's important. So by being in the homes is important, just by being there, showing that your care, that they should care as well.
Yeah, no, thanks, Dr. Dadani. I will make one comment, and sorry, my video is still off. It's just helping with my internet stability. But certainly your comment about aspiration pneumonia is a good justification for, like the work that dentists and dental hygienists do for older adults. Aspiration pneumonia is, one of the leading causes of death amongst long-term care residents in around the world. And certainly us reducing the level of bacteria in their mouth through professional dental cleaning is helping in that regard. And there's some good literature to support that statement. And certainly the work that caregivers do and care aides do in long-term care certainly helps with reducing the risk of aspiration pneumonia as well. So it all helps. Keep the mouth clean,
For
Thanks.
sure. No, for sure. And you raised a really good point. I think I had an aha moment when I read one of those studies, which was from the US, where they had done a survey, a long-term survey of the number one reason why elders from long-term care passed. And the number one reason was because of pneumonia. And when they went to culture the bacteria that caused the pneumonia, the bacteria was from the mouth. And for me, that was an aha, because that really took this idea of, plaque in the mouth to a whole new level, because now we're talking about a potential risk to life because of that. And I think that, your comments are really valuable, because we really need to underscore how important having a clean mouth, having less bacterial load is for the elders' overall health. So what's the role of the nurse, the care aide, and the family in oral care? So there was a publication, there was an article in the Journal of the Canadian Dental Association in 2006, which the title was Uneasy Dental Services for Frail Elderly People. And what was meant by uneasy was that there's vague regulations out there across the country. There's vague regulations in British Columbia around dental care and the legislation around that, in the sense of the enforceability of that. There was a conversation around whether a standardized oral health assessment would be something of value. There's good work being done in Ontario around OHATs, or the oral health assessment tool that's being used there. Sometimes there's relatively low priority given to oral health when it comes to elders. And that can be because of perceptions that staff may have, or perceptions that family have around how important the teeth are, and how the teeth are, or the mouth is, so intricately tied to overall health. There's good work being done in Ontario, again, by this time, the Registered Nurses Association of Ontario. They have an excellent webinar called Oral Care Best Practices for Residents with Responsive Behaviors. So here in this webinar, it's fairly long, but really packed with great techniques, where they go into the actual techniques for brushing for elders who basically won't let you brush. And I think it's a very valuable webinar for everyone to see. The good news is that a champion can make a huge difference. A champion in the care home can make a huge difference. And here we have the example of Prince George. And definitely this is where Dr. Wilczek has a lot to add in terms of the Prince George model that's worked really well.
Thank you. One of the good things that I feel about the Prince George program is that it removes the financial barrier to the family. And in terms of getting consent, it's an easier process. And the other thing, from the home's point of view, they have a dentist to call for each home. And that really does kind of complete the loop. So if the staff see something, it's not that they're searching who to call. They have a specific person that's responsible for the care in that home. And I think that's what I see as some of the values of the Prince George program, that it's part of the services covered as all the treatment that they're getting. Oral health is one of the services, that it's not separate. It's not a separate fee that the family has to bear.
And this is done in partnership with the Northern Health Authority,
Yes.
right?
Northern Health, we have a contract with Northern Health. We're given a number of visits, usually about one visit a month per home for about 3 hours, and they're allowed one hygiene visit per month per home. And it seems to be adequate. Would we like a little more? The answer is yes, but I think it's a doable situation. At least we have a way to deliver care to the patients that need it, and they're being assessed and checked, because our goal is to make sure every resident gets an exam once a year. We don't always meet that goal, but we try.
So now with the federal government announcing, hopefully, announcing that, there's going to be dental care for families, individuals, and, they've talked about what it's going to look like. It will definitely include seniors. Hopefully we'll be seeing there then the ability to have a similar idea in terms of the financial compensation. But what won't be answered is what you have there in Prince George, which is having somebody coordinate it. And so can you talk to us about that, the benefits of having that?
Oh, that is the critical piece of every program, is to have a coordinator. Our coordinator is a public health hygienist that works for dental public health. And I always look at it as the glue that holds us together. And we have actually formed a geriatric study club to talk about issues and how to promote seniors' health, because we all work independently, and because we assign one dentist per home, so that everybody's familiar with that home. They're familiar with the residents, they're familiar with the paperwork, and it makes the interaction go smoothly. But the coordinator, and to have somebody advocate for us at Northern Health, because she's a rather senior employee at Northern Health, so it really does complete the loop. And it's important that the management of Northern Health values this program, and they have, because our program's been going for started in 1995, so it's 27 years, and we've never had a cutback. We get letters that they see value in the services we're providing for them.
That's amazing. And maybe, Nicholas, you can also talk to us about the importance of having a champion in the care home. So somebody there who is advocating for having the dental professions come in, is coordinating that, is handing out the information to families and new admissions. Could you just speak to us a little bit about that from your experience?
Yeah, actually, maybe before I comment on that, I see Dr. Vansickle is here, and I don't know if Dr. Vansickle wants to make a comment on the Prince George thing too, because I know he's involved. Hi, Dr. Vansickle.
Oh, perfect. I didn't even notice him, so that's great.
Yeah, I finally figured everything out. In Prince George, Richard has been with the program since day one, Richard?
Yes.
So he can give you far more facts than I can. I can just tell you that the residents, the staff in each home take great comfort and even pride that they have a dentist they can phone. The families are appreciative. The clients are appreciative. We may not get to do what we want to do, but we give them an opinion and they can make an informed choice.
Thank you. And thanks for joining.
Yeah, so Dr. Danny, I'll make a comment about your second question about sort of that oral health champion. Certainly having a champion in long-term care homes is really important for the reasons that Dr. Vansickle and Dr. Wilczek said. It's like just someone that the long-term care home knows that they can call. That's really ultimately at the end of the day what everybody wants, someone to help out when someone actually needs help. So certainly, the long-term care homes that we're affiliated with here in the Lower Mainland with the UBC Geriatric Dentistry Program have that point of contact, because we're very fortunate in our program to have really strong administrative support through the university, which helps us to do, our teaching requirements and our research requirements and like the service piece. So certainly, at the end of the day, caregivers just want to know who to call if there's a tooth problem, and that's what everybody wants to know. And the folks in Prince George are very fortunate to have Dr. Wilczek and Vansickle offer those services up there. And we wish there were Dr. Wilczeks and Vansickles in every community across Canada. That would be the best. But that's unfortunately not the case in many parts of British Columbia and across Canada. Yeah, thanks.
Part of the benefit we have in Prince George is it's Richard. Well, Richard's an original citizen. I've been here 45 years. You get to know the community gets to know you. It's easy to get around in. It's the homes that we have. There are dental offices if they need out of home care close by. It's just more convenient for us than in the big city.
Thank you. So this idea of assessment improving outcomes. So this is assessments by the staff, but also by dental professionals. And so there are a lot of resources. And again, if you have access to these slides at a later date, you can always look at these resources that are there. The BCDA provides a tip sheet with photos around what caregivers or staff should be looking for that would trigger them to consult with a dentist. As well, there is advice that we could give in terms of nursing staff for possible signs of an infection and when you definitely need to have a dentist in the picture. And that's if there's swelling in the mouth. If you were to tap on the if you were to tap on the tooth with the blunt end or the non-brush end of the toothbrush, or with the end of a spoon. And if it hurts to tap, then again, there could be an infection. If the elder is complaining about when they drink cold and it lasts and they're touching their mouth, perhaps they're not complaining, but they're touching their mouth or they're not eating, all of these things could signal that there's an infection in the mouth. And that is a major source of pain, but it's also a huge impact to the overall health of the elder. And then the importance of regular professional dental exams and dental hygiene or tooth cleaning by a dental professional. I'm just going to share a couple of photos before I pass it on to my colleagues. These were photos shared to me by a dentist who was doing a cleaning for an elder in long-term care. This dentist has had 30 years of experience. And, she was relaying to me that Salima, I cleaned his teeth. It was an 80-year-old gentleman. He was completely cognitive. He knew what was going on. He brushed and flossed his own teeth. He was very proud of that. His mouth was fairly clean. And when I sat him up to take some x-rays, I didn't believe what I saw, that the tooth that I had just cleaned had a huge cavity on the x-ray, but it was below the gum line and at an angle, which I couldn't feel when I was doing the cleaning. And this really speaks to the importance of making sure that the elders who are able to have regular professional dental exams with x-rays are able to access that as well. We know that sometimes in some situations that's not a possibility for our elders. If the care is happening in the care home, then it may not be possible to have the x-ray, but still possible to have the dental exam and to have the oral cancer screening. I'll pass it to my colleagues. Did we want to start with Dr. Wilczek? Did you want to start?
I was going to just a comment on the x-ray. One thing we do find is that the teeth decalcify. That means they do not cavitate. And that's why when you look at that image where you see that there large carious lesion on the distal, I'm assuming that's a 4 or a 3, is the tooth isn't missing. The tooth is soft. And I've really come to light when I saw a patient that was in long-term care for close to 20 years. Her teeth literally became soft. I have never experienced the teeth. You can bend them. You can bend them like 30 degrees. It was like, I couldn't believe that was actually happening, because one of the things we don't know is how long we can keep seniors' teeth in long-term care. Can we keep them there for 10 years? We know we probably could do 5, 10, 50. I don't know what the answer is, because it is a difficult environment overall to maintain that level of hygiene and care that you can with able-bodied individuals. So after seeing this x-ray, I'm not surprised that she could not detect the decay.
Dr. Van Sickle?
Well, the facilities I go in, I don't have any access to x-rays unless the client went out of the home. It is, as Richard said, it's quite astounding the amount of decay and flexibility you'll see in teeth, and nobody's complaining. Basically, I think we just treat as people complain. We don't treat as we would like. We treat complaints.
Yeah. Dr. Tong?
Yeah, thanks, Salima. So yeah, I agree with what Dr. Wilczek and everyone else has said. I will make one comment on this slide about the possible signs of dental infection. One of the things to bear in mind for us for the caregivers here on this call is that we know that a lot of older adults that live in long-term care, especially those with cognitive decline, sometimes are not able to verbalize well their pain, or they're not able to describe their pain, or even answering, these tapping test questions or ICE test questions and the classic dental questions that we ask to try to identify tooth infections. So some of the things that we do with our program at UBC is look at some of the nonverbal signs of pain. And what I mean by that is like looking at changes in diet, changes in eating quality, changes in behavior, other sort of behavioral changes that someone may undergo if they are not able to communicate well because of Alzheimer's disease or other neurocognitive disorders. And sometimes we rely on those to help guide, our investigations. But that can be quite challenging for us as dentists to try to identify which tooth is actually causing the problem, because sometimes there can be multiple teeth in the same area that are not looking so good to us on the radiograph or in a clinical photograph that you've shown here. And sometimes it's not obvious which is actually the problem tooth. Thanks.
Thank you. So some practical tips for care aides, and we'll just go through this really quickly, but some practical tips for independent residents. So, residents who are cognitive, who really, are with it, they can do it for themselves. They perhaps only may need a reminder to do the toothbrushing, maybe to make sure that they have the supplies that they need and that those supplies are well labeled, and that if you are going to help any of your residents, that you're always wearing gloves. Sometimes for elders, as for any of us, when needing a little bit more help, an electric toothbrush can work. Some elders do not like the electric toothbrush because of the noise and the vibration, but that is something to think about, as well as adaptations to the toothbrush, which may include adding some bulk to the handle so it's bigger so that they can hang on to it. Many of the things that a physiotherapist or an occupational therapist would be able to identify. For residents that need help, making sure that you're doing a daily inspection of the mouth and using a flashlight because it's dark in there. You want to be able to, if you are helping them with toothbrushing, to use a pea-sized amount of toothpaste. You want to be able to remove their complete denture, partial denture, ask them to remove it. They may need help, but you do want that partial or complete denture out of their mouth so that it can be cleaned and that the mouth can be cleaned as well. And to report anything to the nurse that is unusual. So if you do see something when you do that check, if the gums are bleeding for more than a week, if the resident is refusing care, which is a change from how they used to be, or as Nicholas mentioned, if there's a change in eating habits. And of course, many of you may already know this, don't put your fingers in between their chewing surfaces of their teeth because, it's not that they mean to, but it's just a reflex to bite down when there's something in between the teeth. And then some ideas around the unconscious resident is using a mouth prop, and there are foam mouth props that are available on the market, turning the resident's head to the side, lubricating the lips, moistening the toothbrush with a fluoride mouth rinse instead of toothpaste, using a gauze or a towel to soak up any moisture. We have another slide, and I'll go to that next, and then I'll ask my colleagues for additional tips. If there are dentures, asking the resident to sip some water to moisten their mouth, to help them remove their denture if they're able to do it themselves. Trying to help elders remove their dentures at night. Many elders don't want to do that. So it's a journey of trying to get them to remove it at night. It's really important. It allows the tissues in the mouth to rest. making sure the dentures are labeled. Oftentimes we hear from families where the dentures get lost or misplaced and then can't figure out which dentures are whose. So having the dentures labeled, and if they're not labeled, suggesting that to the families. When you do help an elder with the cleaning of the dentures, to do it in a way that prevents the dentures from the potential of breakage by doing it over a towel lined or a water-filled sink, so that if you accidentally drop it, it can land softly. Using liquid hand soap, a pea-sized amount, instead of toothpaste on the denture, because the toothpaste can scratch. And ideally, you want to be cleaning the dentures twice a day and having the resident rinse with water after meals. Now, this is an ideal, may be difficult to accomplish. We talked about dry mouth already, so I won't go to that, but I'll ask my colleagues if they wanted to add anything more.
The only comment I would add, because it's the first time I had saw it when my last visit, was now implants are changing at the dimension of prosthetics, because some things that look like dentures do not come out.
Yeah.
Some dentures have little attachments that make it harder to come out. So for care aides, there will be a new piece in their education that will have to be required, because I think with time, there will be more of these implant prosthetic devices that will be in the seniors' mouths that they'll have to pay special attention. Otherwise, I agree with those tips 100%.
Thank you.
I agree with Richard. The overdentures on implants are becoming a little more common, and the actual residents sometimes has trouble themselves in taking it, let alone a care aide.
Yeah.
And yeah, I have nothing really special to add. I think that's great, Salima. Thanks.
Perfect. So then the role of the family member. So, there is a role to be played by some family members, as a champion, potentially as a coordinator, but that family member needs to be aware of the importance of the good oral care. They need to understand their own perceptions and their own importance that they place on oral care. Some family members may be hands off, and family members really need to be collaborative when, working together. It's really only in a collaborative environment where the, family member, the dental professional, and the staff, if they're all working together, it makes for the best outcomes for the resident. And again, the role of family members may be, and it's an area we're exploring with the BCDA in terms of helping with daily mouth care. How can we provide resources for family members so that they can be a champion, a coordinator, and then they can help with some daily mouth care. There may be a greater opportunity with family members because they're there for, some of them can be there for a longer period of time, so they have time. The resident might feel more comfortable with them, and the resident may give them consent where they may not be as consenting to others. But those family members would need training and resources to feel comfortable in that case. So I will ask my colleagues.
I would agree with you, because any person that's in residential care that has a family advocate, it's important, because it's just a reminder for the care aides, but also when they visit, if they can be encouraged to ask them if they brush their teeth, maybe watch them brush or help them brush their teeth. Advocacy is so important. It doesn't matter what type of care. Once you have an advocate, the care usually goes better.
Richard has nailed it there.
And Nicholas?
Yeah, no, Richard is totally right. Having an advocate is the best thing. That's what drives a lot of the patient care that happens for us in our program, certainly. And it is so important, because older adults, particularly those that live in long-term care, sometimes are not good advocates for themselves. Like they are not good at vocalizing their issues. So, and sometimes they might not feel comfortable expressing their concerns to nurses or to dentists or to other oral health professionals, but they might feel more comfortable expressing it to their family. So, if that's the case, then that can certainly help. everyone involved, right? We just want to make sure people don't get toothaches or infections and can keep their teeth as long as possible.
Awesome. So what do we want for our elders in long-term care? We want them to have quality of life. We want them to have dignity, the ability to socialize, eat, be pain-free, and be comfortable. From the Journal of the American Dental Association, there was a paper which stated regular hygiene to reduce bacterial invasion of the lungs, to be pain-free, and the maintenance of dignity. And so we really are appreciative to the BC Care Providers Association for hosting this webinar. Really appreciative to our members, Dr. Wilczek, Dr. Van Sickle, and Dr. Tong for joining us on this, and for you to participate and ask your questions. So we can go in the last 10 minutes right to our questions. So I'll ask Carrie if there were any questions that came through that we weren't able to answer through the presentation.
Thank you. There was one question that we have, and I'll just read it out. Is there any way to convince MSP to pay for a yearly exam by a dentist? Ontario has been doing this since the 90s, with OHIP paying for a yearly dental exam of every patient in long-term care. The yearly exam is a requirement for the facility's accreditation.
Yeah, that's a great question. And it's a question that the BCDA has been advocating for many years. With the announcement of the federal dental program, we're extremely hopeful that not only exams, but cleanings and some treatment will also be covered by that plan for our elders in long-term care. So it's a fantastic question. As the federal dental program, more details are announced, the British Columbia Dental Association, as well as all the provincial dental associations, as well as the Canadian Dental Association, will be working with their respective governments on what the plan will look like, what it should cover, how much it should cover, what the limitations should be on it. And so we look forward to working with the Care Providers Association to hearing your feedback as well of what we should take forward in respect to this federal dental plan and how it should work. Dr. Wilczek?
The only comment with MSP is very few dentists have MSA or hospital numbers. I do, because I work in the hospital as well. So I do bill through MSP for services provided in the hospital, but it's only a small portion of dentists that have the ability to bill through the medical services plan. So that's why it's not a workable option. And that's why, in terms of when we designed the Prince George program, we didn't even go through that option because it's not workable.
Yeah, I'll also make a comment too. You know, at this point in time, the federal program that Dr. Dadani was describing, it's a wonderful announcement by the government, and it's a very significant announcement, the biggest one in dental care in probably 50 years in terms of, you know, like the scope or the intent of what they're trying to do to cover uninsured people across Canada. And it's a wonderful initiative, but certainly the details of what they're describing.
Dr. Tong, we're just losing you in terms of internet, but we did hear snippets of what you were saying. Yeah,
sorry. I think I'm back now. Can you hear me? Can you give me a thumbs up?
Yeah, we can hear you clearly. Yeah. It's all good. So Carrie, was that it for the questions?
That is the only question. There was another comment added on to that original question saying the MSP number is very easy to get. I'm not sure if anyone has a response to that.
I think with the federal dental program, that might be something that's moot. So hopefully, you know, the federal dental program will be the way that we bill normally with insurance. And so we will be looking forward to many more dentists being able to participate, as our elders are able to participate as well. And so again, really wanting to thank everyone from the BC Care Providers Association and all our everyone who participated. We'd be happy to hear feedback. Please contact us at the British Columbia Dental Association if you have any feedback for us, or if you think there's other ways that we can collaborate in order to provide better oral health care outcomes for seniors. You can reach us at the BCDA by emailing us at info@bcdental.org. So again, a huge thank you to our panelists. Thank you to Melissa and to Carrie for hosting and organizing this webinar today. Thank you so much.
We actually had one more question come through in the chat. We have a couple minutes to just do a quick answer. Someone said, we had a resident who had a blood infection and died. The cause was related to the hygiene he had 4 days before. Does this happen often?
Dr. Wilczek, you're on mute.
Melissa, I can sort of field that question. I would say, you know, our experience is that fortunately that's uncommon. That's not a common thing that happens after dental. I don't know the specifics of that particular case, and there may be other factors involved in that case that may have like the link between those two. But fortunately, blood infections after dental hygiene is extremely uncommon, but has been reported in some rare case reports in our literature. Thanks, Melissa.
Any last minute questions before we're done? If not, we will be emailing everyone a recording of the session in case you want to go back and take a look at the slides or listen to some of the feedback from our panelists today. And I just want to thank everyone who joined today, and I hope everyone has a great day. Bye, everyone.